Hello, everyone, and welcome. My name is Dr. Valerie Iovine Rogers, and I'm here today to talk to you about the presentation of your hypermobile population. So, this is a topic that's very near and dear to my heart. To give you a little bit of background about me, I got my Bachelor of Sciences in Health Sciences from Drexel University. I stayed there and I got my Doctorate of Physical Therapy at Drexel as well. I then got to go work at a great company called Strive Physical Therapy. We had grown the largest special interest group focusing on connective tissue disorders and autonomic dysfunctions, which is a connection we're going to talk about today between those two diagnoses. And while I was there, I was honored with a couple of really great accolades that showed that what I loved doing so much was actually working. So I was the Strive Provider of the Year. I was named the Ehlers-Danlos Outstanding Provider of the Year. I got the honor to speak at the Ehlers-Danlos Global Learning Conference a handful of times. You'll see me at the Scientific Symposium presenting, as well as throughout the EDS ECHO courses presenting and facilitating a bit. The Ehlers-Danlos Society works with ECHO, which is an outreach program, and I've taken all of their classes, then I grew to facilitate some of them, and now I even get to present. So this is a topic I'm very passionate about presenting about. I make no secret, I am very open of the fact that these diagnoses directly impact me in my life, and I'm very open to sharing my story and how things have shaped and changed me. And it's a lot of how I've learned how to treat a lot of these patients is by going by what has worked for me and now has helped so many hundreds of patients with these disorders. So I'm really excited to share these things with you. I had to take a step away from my clinical care for a short while because of a neurosurgery that I had to get because of these manifestations of these connective tissue disorders. And in that time, I was so nervous I wasn't going to be able to go back as a physical therapist, what I loved doing, helping this underserved population. And so I went and I got my wellness counseling certificate from Cornell University in hopes that I could still stay in contact with these patients and help these people. And I'm lucky enough that I get to blend all of my passions together in this role that I'm in now. So I'm one of the program managers at the Cohen Center for Recovery from Complex Chronic Illness at Mount Sinai's Icahn School of Medicine. And I absolutely love what I do here. I get to tie in a bit of research about connective tissue disorders and autonomic dysfunctions. I get to educate both internally to our own team and provide in-services and educational opportunities to other providers so that more people can learn how to best treat patients with hypermobility. So without further ado, I'm going to go ahead and share my screen so that you have the opportunity to follow along with me as I present about the hypermobile population. There it goes. So it seems you should be seeing my screen now. And so as you can see, today our topic is hypermobility. And right on the first slide, I say management of connective tissue disorders such as hypermobile Ehlers-Danlos syndrome. And so why do I put a specific diagnosis on the first slide? That's because when you say hypermobility, more times than not, you're going to have somebody guess the diagnosis at hand is hypermobile Ehlers-Danlos syndrome, but it's a lot more than that. So there are hypermobile spectrum disorders, HSD. It's an umbrella term, but it also can be a standalone diagnosis. And a hypermobile spectrum disorder is really another term for a connective tissue disorder. There are several connective tissue disorders. There's the Ehlers-Danlos syndrome, and there's 14 different types of Ehlers-Danlos syndromes. The most common type is the hypermobile Ehlers-Danlos syndrome. So you'll hear that as HEDS, as the hypermobile type, as hypermobile Ehlers-Danlos syndrome, and they used to number the types. It's a bit outdated now, but if you see it in the literature, it was once called EDS type 3. So like I said, there's 14 types. They are all going to present with that hypermobility. They have varying different specialized characteristics that set them apart. Aside from that, we will touch base on the vascular type. That's one of the more lethal side of the Ehlers-Danlos syndrome. We're going to talk about that at the end of the presentation. But connective tissue disorders are not limited to EDS. There are also Lewy-Dietz syndrome and Marfan syndromes and so many other connective tissue disorders. And we're having such an uptick in seeing more patients with hypermobility. And a thought of this is both better awareness and also that people are getting harm to their connective tissue from outside factors. So one way that we're seeing this is in patients with long COVID, for example, and other post-acute infection syndromes, we're seeing there's a bidirectional relationship. In one hand, people with existing hypermobility are more susceptible to developing those post-acute infection syndromes. But on the other hand, people who have something like long COVID or other pathogen persistence or issues along those lines are having their connective tissue being broken down by those pathogens and presenting with either new hypermobility or hypermobility that's just becoming painful and noticed. So you're going to hear all different terms referring to this hypermobility, but the real umbrella term that we're talking about is either a hypermobile spectrum disorder or a connective tissue disorder. And let's clarify first, again, before we really get into this very first slide here, there's a difference between hypermobility and flexibility. Flexibility is usually going to be talking about that musculotendinous length, that trainable length that if you keep stretching your muscles, they will get longer and longer. Yes, if you stretch a ligament, it will get longer too, but we're talking about that articular instability, that hypermobility at the level of the joint is really the hypermobility that we're talking about in these disorders. So you can see here, the hypermobile spectrum disorder has an array of presentations. So when you see a spectrum, usually you think of something like what's pictured here. You have that white side of the line where it has mild HSD, and it goes all the way up to that dark red representing severe HSD. And yes, there are mild forms and there are severe forms and there's everything in between. But the reason we can't look at HSD on a linear spectrum like that is because there's so many aspects to a connective tissue disorder. So the line below it shows that rainbow complex, and it has a couple other labels on there, and that's a bit better of an articulation of what the spectrum really looks like, but even better are these pie charts on the side. So if I direct your attention over to the spectrum disorders, but in these pie chart forms, it really articulates that you can have all sorts of issues. If you look at person one, this pie chart says they have a lot of joint instability, anxiety, pain, they have a decent amount of headaches, but they really don't have much of an issue with mast cell activation syndrome or with GI issues. So that's a common presentation. You might see patients like that. You might also see someone who's more like person two that's shown on the slide. That person doesn't really have a lot of anxiety. They don't really have a lot of fatigue, which were two of the main problems with person one, but they have a lot of GI issues, a lot of dysautonomia, a lot of mast cell activation syndrome. So it really shows that in a connective tissue disorder, it impacts so much. Think of all of the places you find connective tissue and all of the disorders that can come from it if it's not right. And so in these different presentations, some people will pull and it'll magnify in their body one issue and it won't be as much of an issue somewhere else, and vice versa. Or maybe all of them are a huge issue, all of them are a slight issue, and varying degrees of everything in between. So keeping in mind that you have all different presentations of how somebody's going to look with a connective tissue disorder. But I think a good place to start is really understanding the start of these connective tissue disorders. What happens? And so in a lot of the types of Ehlers-Danlos syndrome, which is a very common cause of these connective tissue disorders, there is a known collagen deficit. But in the most common type, the hypermobile type, HEDS, we don't know what type of collagen, we don't know what gene it travels on. It seems to be genetic, and we hadn't found the reason. So just recently, out of MUSC, they had found there may be a consistent gene, the kallikrein 15 gene, or KLK15, that has this mutation. And if you follow the effects of that, it would overactivate your kallikrein system. That results in too much bradykinin, and bradykinin has a lot of known effects. Bradykinin is a known vasodilator. It can trigger a lot of other cascades, like your matrix metalloproteinases to activate. And that's actually where one of these other studies picked up. So there's an Italian group on the section below here, and what they found is there's elevated levels of ECM degradation fragments. So the extracellular matrix is breaking down in patients with hypermobile Ehlers-Danlos syndrome. That connects to the study above really because in that kallikrein overactivation and that excess bradykinin, we're triggering these MMPs. So these matrix metalloproteinases are responsible for what's going in, breaking down this connective tissue. And the exciting part of the latter study here is it might give us a biomarker to look at, but I also think that both of these studies, when combined together, give us a great window into understanding HEDS, that this is a connective tissue disorder. It has some extracellular matrix dysfunction, and where we thought this was once a non-progressive disorder, of not being able to build up your collagen the right way, as a lot of the other Ehlers-Danlos syndromes are. In hypermobile Ehlers-Danlos syndrome, it looks like it's more of an issue of the breakdown of those fragments of the connective tissue and the extracellular matrix. So just an interesting take to show Is it progressive? We're not quite sure. Sometimes it seems progressive to certain patients because of the way they present, and we're going to get into some of the comorbidities that really cause that feeling. But it's very important to just take a look and see if your patient has that hypermobility, because ultimately that's what you're going to be treating. So we'll get into the physical evaluation, and in 2017, there was an HEDS diagnostic criteria sheet that was published out there, and it has 3 criterion. The first criterion talks about evaluating for generalized joint hypermobility. The gold standard for that, as of right now, is the Beighton score. So the Beighton score is out of 9 points. It's a point for each side for 4 different items, and then 1 point for something that's not bilateral. So we'll start right in order. So the way that Beighton scale works is they're looking for your pinky finger to hyperextend, going to 90 degrees. The best way to test this is have the forearm flat on something and then lift that pinky finger up and see if you're reaching 90 degrees. If you are, you get a point for each side. So 1, 2, possible 2 points for the pinky fingers. Then we move on to the thumbs. The thumbs, we are looking for essentially more hyperflexion of the wrist. And what you're going to do with that one is you take their thumb, you bend it down towards the volar aspect of their wrist. I want to make that clear. A lot of people with the Beighton scale will try to go sideways or backwards, and they don't really know what that thumb movement is. It's going to the volar aspect, so that side with the palm, the volar aspect of the wrist for the hyperflexion of the wrist for the thumb test. If you have that touching on both sides, you'd get a point for each side, so possible of 2 there. The third item is the elbows. We're going to take a look if they hyperextend to 10 degrees. You'd have the patient straighten their elbow all the way out and take a measurement with your goniometer there. Positive point if they're reaching 10 degrees or more, point for each side if relevant. And similarly with the knees, you'll have them stand up, lock their knees all the way back. That is something you'll want to untrain once you are working with them in physical therapy. But you're going to take a look at that genu recurvatum, see if their knee hyperextends to 10 degrees or greater. If it does, they get a point for each side. And finally, the reason why it's an odd numbered scale, 9 points, is because the last test looks at the spine. I think it really looks a lot at the hips as well, but you'll have the patient standing with their feet flat, bend over and try and get their palms touching the floor. If they can do that without bending their knees, they get another point. So if somebody has both pinkies going to 90 degrees, both thumbs going to touch the volar aspect of the wrist, both elbows going beyond 10 degrees of hyperextension, and both knees going beyond 10 degrees of hyperextension, along with that palms to floor test, they get a 9 out of 9 on the Beighton scale, which is not necessarily what you need for diagnosis. So take a look at the slide here. There's a couple of checkboxes. This is directly out of the diagnostic criteria that's out there. And there's a couple different thresholds based on ages. So for children who've not yet hit puberty, they need 6 or more points. For men and women to the age of 50, they need 5 or more. And beyond the age of 50, you need 4 or more points on the Beighton scale. And then there's a list of questions where if they're not meeting these thresholds, you can ask if it's something they were once able to do. All of this said, the Beighton score does not come without limitations. So the Beighton score, like I said, 9 points, but 4 of those 9 points are coming from the hands. And the hands, while very functional and very necessary and usually hypermobile, in a widespread connective tissue disorder, a lot of times patients won't list the hands as one of their top priorities. So keeping in mind that that's also a very focalized segment of testing, that 4 of the 9 points are coming from hands and something that should be so widespread. So a couple limitations to think about there. Then we also have the elbows and knees, and we're looking for 10 degrees of hyperextension. It's a lot of hyperextension, actually. Not to mention that the elbows, you could have a bony stop, a bony limiting factor, and it wouldn't have to do much with your connective tissue disorder. And similarly, you could have joint congruence that doesn't allow you to hyperextend your knees, not reaching that 10 degrees of hyperextension. So maybe you're not getting the points for that reason. And then finally, when we look at that piece that they're saying evaluates the spine, I think is really for hips as well. When you go to bend over, there's a huge confounding factor when we talk about your hamstring length in looking at that test. So in patients that have instability in their low spine or in their hips, or they're generally in a lot of pain, they're going to have tight or even spastic hamstrings that are going to limit that range of motion. So there's a good chance your patient's not going to be able to reach the floor. In fact, there's a good chance some of your patients don't even necessarily look entirely flexible because of that muscular tightening I was just talking about. So we want to make sure we're looking at articular tests that are looking for joint instability. So all of the tests on the screen here are existing special tests that are validated in the literature pretty heavily. We are clustering them together. We're looking to give them a new scoring scale. So that's what's novel about this cluster of tests. We're calling it the iodine cluster here. And the load and shift test and sulcus sign both look at the shoulders, the hip dial test for the hip. Patellar translation is in addition to that genu recurvatum. We're going to score both of those things. So in case they have that joint congruence limiting that patellar translation, that way we get still a picture of the hypermobility of the knee. Ankle inversion range of motion, and a navicular drop test. So a lot of these you might be familiar with already since they are already existing tests. Like I said, that difference is going to be the scoring. So if you're familiar with the load and shift test scoring, they grade it from 0 to 3. So you grade 0, 1, 2, and 3. And we've actually applied that to all of these tests bilaterally. So that makes a total of 42 points. That way we're not looking at a dichotomous test. You know what? You don't have 10 degrees of elbow hyperextension. You don't have EDS. I don't feel like that totally fits. And so that's why we're really expanding it to look at this cluster to see and grade joint hypermobility, joint instability. So 0 would be hypomobile, 1 would be normal, 2 would be mild hypermobility, and 3 would be severe hypermobility or resting subluxation. So to remind you of some of these tests, I'm going to play a video here. It'll go through each of those items and explain to you how to perform the test. The load and shift test is performed by translating the humeral head anteriorly and posteriorly. You can see here the patient does translate significantly anteriorly. You are feeling if they ride onto the labrum or even past the labrum, both indicative of a positive test, and if it resolves on its own. The assessor can grasp the arm above the condyles and give an inferiorly directed axial tension. You can see here the patient does have a gap, and that is called the sulcus, between the acromion and the head of the humerus. Performing the hip dial test is in supine with the patient's heels on the table. You can see this patient has a resting hip dial sign, meaning that their hips already are showing laxity and the fact that they do not point up. You will take the patient and roll the leg inwardly and outwardly, alternating between internal rotation and external rotation. Do not give the patient a warning as you end on external rotation. That way, they do not have a heads up and do not use the muscles to pull the leg back into a neutral position. This is what you are looking for here. You're watching to see if there is a rebound back to a neutral position or not. Do note you cannot move the leg via the ankle. They probably also have hypermobile ankles. Knee hyperextension is an important test to measure, but you also want to look at the patellar translation, so grab by the 4 quadrants and translate the patella and assess if hypermobile. With the patient's feet off the edge of the table, you can also note the resting position here if they are already inverted. Do measure the inversion range of motion of the ankle, looking for something above the normal range of motion here. Point and mark the navicular on the foot, as well as that level when the patient is non-weight bearing on a note card aside of it. Have the patient come to a stand, and then mark the new place where the navicular lands on the paper. Measure the distance. So that is your iodine cluster. It's those existing tests that we're going to grade just a bit differently as we go ahead and evaluate for articular hypermobility. I also made a note in this video of a couple places where you want to take a look at how the patient is sitting or lying before you even put your hands on them. So if they are lying down, are they already in a hip dial sign? Does that mean they already have that lack of competency to hold those legs up towards the ceiling? That would be the same thing that you would see in the hip dial test, but you might even see it at rest. Do they have a resting anterior subluxation of the shoulder, which is kind of like that load and shift test anteriorly, which we're going to talk a bit more about those subluxations too? Or do they have a resting sulcus sign of the shoulder? Are they moving and fidgeting and they can't stay still? Do they have ankle inversion at rest? And that would show that there's really not a lot of competency of the lateral compartment of the ankle because they've probably rolled it so many times and it's become so lax. So there's a lot of things that you can pick up on with your patients when they go to stand up. Do they maybe push off of the table and their fingers bend all the way backwards, or things like that that can really clue you in to better evaluate for hypermobility right off the bat. Move on to our next slide here. So, like I said, that first criterion is the Beighton scale. I like to supplement it with that iodine cluster we just shown here. And then there are two more criterion for the formal HEDS diagnostic criteria. We have criterion 2, which is made up of three features, feature A, B, and C. You need two of the features to be positive to get a positive criterion 2. Doesn't matter how you make it up, if it's A and B, A and C, B and C, whatever the combination may be, you just need two of them. So feature A is a list of 12 common characteristics that you see with hypermobile Ehlers-Danlos syndrome, and you need 5 of them for feature A to be positive. So I did give little descriptions for some of the things on the side here, and I'll leave that here for your reference, but I do want to point out just two of the items from feature A, and one of those is the bilateral pysogenic papules on the heel. I have a picture alongside here, and what it looks like are like little bubbles when someone comes to weight bear on their feet and they appear on the heels. And I explain these to my patients because usually when I'm looking for them, they actually have no idea this is something they've already had. They're totally harmless. You don't feel them. So pointing them out to your patients can cause a little bit of alarm. So you want to educate them that these papules on the heel really come from the connective tissue laxity that's in their lining. So I explain that a lot of times. If you know the 90s toys and it's like that gooey little tube and you squeeze it and you watch all of the liquid ooze through the netting, right? And you see those little bubbles. It's a similar idea here. So the pysogenic papules, if you think about how connective tissue should typically sit, you can see in my hands on the thumbnail here where my picture was, you can see your connective tissue should be solid and sewn together. As it's lax, you're going to have more spaces, and that space is going to allow the tissue to be more porous. And that porousness is what allows when you go to weight bear and you put weight on your feet, some of the fluid and the fats are going to seep through some of those openings in the connective tissues, and they create those pysogenic papules. The other item in criterion 2, feature A, that I want to point out is it says arachnodactyly as one of the features. That technically means spider fingers. That's actually classically one of the signs of Marfan's as well, which is another connective tissue disorder. And in these spider fingers, it essentially means abnormally long fingers, and there's two ways to test for it. We either do the Steinberg sign, which is when you put the thumb across your palm, close the fingers, and if that thumb is still coming out the other side, that would be a positive Steinberg side. Or we do a Walker sign. Walker sign is thumb to pinky, not any of your fingers, it's thumb to pinky around the wrist making contact. And so they can have either one of those positive, don't need both, and that would give you a positive arachnodactyly sign. So you only need 5 out of these 12 to be positive. Not all of these can be assessed in a rehab setting. For example, it talks about mitral valve prolapse. A lot of times your patients, you'll say mitral valve prolapse when you're asking this question and they'll not know. That means they probably haven't had one, but let's make sure that we evaluate for that. So we do refer out to cardiology, also because we can't take that aortic root dilation Z-score either. So we refer out for cardiology just to get those measures, also to rule out that vascular type and any other connective tissues disorders, which we're going to talk about in just a moment in criterion 3. But to stick with criterion 2, we have feature B and C left. Feature B is simply asking if there's positive family history of your direct family with HEDS. And feature C is asking if you have that joint instability. So it's basically a subjective reporting of instability, dislocations or subluxations without trauma. And the other two questions on there are asking essentially for chronic pain. And so you only need one out of that feature C. So if they come to you saying my joints are unstable or I have chronic pain, they've already got feature C. Criterion 3, I did not picture their full paragraph on here. Basically, criterion 3 is a diagnosis of exclusion. They want you to rule out other types of Ehlers-Danlos syndrome, other connective tissue disorders, especially the vascular type. We want to rule out some of the other things that can make you hypermobile and see if that would be a better diagnosis than HEDS. In some cases, it'll be a better diagnosis than HEDS, and that's what you should go with. But HEDS does not occur alone. And so that's really important to keep in mind. That's why I'm a little bit moving away from criterion 3 a bit, as we're seeing HEDS overlap with a lot of other conditions, so you don't have to have it alone. But why does it matter to get an evaluation and a diagnosis? There's a bunch of reasons. First of all, the patient matters, what they have matters, and their validation is huge. These patients have been invalidated time after time again most of the time. And so this is the population you're going to hear I was told it was all in my head. I was told it was growing pain. I was told I was crazy. I was given uh, anxiety and depression diagnosis, which might be true. They might have anxiety and depression, but that would really come from the fact that they can't figure out why they're in pain all of the time. And they're not crazy. These things are very real and objective. So those are all things that I reassure my patients in my evaluation. You are not crazy. This is not in your head. I have found objective findings that confirm what you're talking about. You are not making this up. I believe you. All of those things are going to go so far with these patients because they've just been invalidated because so many of these reports sound so crazy, but they're real. The other reason why a diagnosis can be so important in this population is because there is so much that can come alongside HEDS and other hypermobile spectrum disorders. Most often, you're going to hear about the trio. The trio includes HEDS, POTS, and mast cell activation syndrome. We're going to go into all three of those, so I won't leave you too much on this slide about that, but I do want to direct your attention to that's not all. There's so much that can go on alongside HEDS, which is so much to deal with in itself. So you might have MALS or gastroparesis, dysmenorrhea or scoliosis, and we're going to talk about these things. You can have a handful of neurologic manifestations. You can have one or you can develop all of them. And so these patients get to be very, very complex with many diagnoses, with lists of things that are 100 letters long of all the diagnoses they've collected if they're finding the right providers. Or they're going to come to you, they're going to find that they're hypermobile, and you'll help connect these dots. And that's why it's so important to learn about some of these things, whether they're rehab based or not, as a physical therapist or occupational therapist that's helping with this rehab treatment. So POTS actually is something that's very relevant to rehab. I'm actually going to do an entire lecture on how to address POTS. What it stands for is postural orthostatic tachycardia syndrome. And what you would think from that name is that when they go to stand, their heart races. And yes, true, when they go to stand, their heart races. But it's so much more than that. So POTS is a dysautonomia. And as a rehab professional, we know dysautonomia, dysfunction of the autonomic nervous system. Your autonomic nervous system is in charge of all of those automatic or involuntary functions like heart rate and blood pressure, digestion and temperature regulations, and the list goes on and on. So you can use your clinical judgment here. If they have POTS or what looks like POTS, then they have this dysautonomia being its umbrella term. And if you know everything that's wrong or everything that can go wrong with the autonomic nervous system, you can connect a lot of the dots for your patients and help them understand what's really going on. But one of the things that you can also do in your evaluation is you can amaze them when they start talking about their POTS or you start suspecting POTS. You can ask, oh, do you have problems with your temperature regulation too, or something like that? And they're like, oh my gosh, how did you know? And so you can help really connect those dots. There are different types of POTS. We have the neuropathic, the hypovolemic, and the hyperadrenergic types of POTS. The neuropathic is talking about having poor control of the vasoconstriction and vasodilation of your blood vessels. So if you can't control that, you're going to have a lot of vasodilation and therefore a lot of gravity winning, pulling that blood to the ground, and you have a lot of pooling in the lower body, in the lower legs especially. Similarly, in hypovolemic POTS, you're still going to have an issue where most of your blood is down in the lower extremities, but that's actually for a different reason. It's because the volume of your blood is so low that it takes a lot more force to be able to get it to fight gravity all the way up to your head when you don't have all of that pressure of the volume to help guide that along. So another issue where you're going to have trouble perfusing the head. And then finally, in hyperadrenergic POTS, this one you're going to have an overactive sympathetic nervous system. So they're going to have a lot of anxiety and tremors and tachycardia and just poor overall sympathetic control of their autonomic nervous system. And like I said, I'm going to do a POTS lecture. We'll get more into detail with these things, but I really see someone who comes in with a connective tissue disorder or hypermobility, they have sort of a combination of the types of these POTS. Sure, maybe one is more of the problem than the other, but if you have these stretchy vessels, because vessel lining is made of connective tissue as well, then it's going to look like you have neuropathic POTS. It's going to look like you're not vasoconstricting because you have so much room for the blood to pool in your lower extremities. Now, because there's so much room for all of your blood to pool in the lower extremities, it's going to look like you have hypovolemic POTS. There's not enough volume to get it all the way up to the upper half of your body. And because your body is working so hard against these overly compliant vessels, then your nervous system might start to over or under regulate either in the sympathetic or parasympathetic regard. And then you're going to have these, excessive responses. So they might look like they have a blend of all three of these types of POTS. And so what's very important is supporting well, first you have to refer to a cardiologist, and really they should manage if the patient is a good fit to increase their salt and their water and their compression. But that's typically a good line of thought for these patients, is to give them some compression. It's supposed to go all the way up from your feet to your abdomen. Nobody's compliant with that. Something's better than nothing. So at least get them some knee-high compressions, and also support that volume with the fluids, but also with the electrolytes so that you maintain that fluid for productive use. So POTS is going to be a huge part of what you have to consider when you're treating your patients with hypermobility, because ultimately what it comes down to is poor upright tolerance. And a lot of exercise occurs in the upright position. A lot of life occurs in the upright position. So a lot of the functional goals you're going to have may be blunted by POTS, and you need to wind up addressing that in your rehabilitation as well. Or you need to match their positional tolerance and your strengthening exercises with that level of percent upright. So we will talk more about this. You can do some tests in the clinic. You can do tilt table would be great, but most clinics won't have that. So you can do poor man's tilt. You lie them in supine, take their vital signs, have them sit up, take the vitals, and stand and take those vitals again. You can do an active stand test where they stand for 10 minutes and you watch how the vitals change over that time, or a 3-minute step test where you have them step, 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 step to the metronome on a little step. And you can, if they tolerate that for 3 minutes in an upright position, that's fantastic. But what's very key about that is noting the position that they're recovering in and watch how long it takes for them to recover. So like I said, more to come on POTS and also how to treat it. So the quick version that I will give you here is that we can refer to the CHOP modified Dallas protocol. That is the most widely accepted protocol as of now for POTS. It's modeled after the Levine protocol, which had preceded it. And now we are creating our own at Mount Sinai, a spin bike protocol that really adjusts for these positions of upright tolerance. So essentially, you need to titrate the percent that you are working upright with purposeful tachycardia. So doing a little bit of cardio, getting their body used to being in a little bit of a tachycardic state in various positions, starting on their back, propping them up a little bit more until they're seated but supported with their legs out straight. So long sit recumbent. And then you'll have supported short sit where their legs are below them, and that's much more difficult. You'll take away the support, you'll eventually have them stand, and so on. So it's a gradual titration based strictly on symptoms, not time-based. This is not something you can go by week 1, week 2. You need to go with how the patient is feeling, and you also need to watch out for post-exertional malaise. So I have to bring up PEM, or post-exertional malaise, while we're talking about POTS, but it's going to be relevant for your hypermobile patients, whether you're trying to forget about their POTS or not. You shouldn't try and forget about somebody's POTS, but this PEM, or you may also hear PESE, post-exertional symptom exacerbation, is going to be a flu-like response, and it has physiologic changes where you need to let your patient recover before you can move on. This is not just them being fatigued or tired. This is a physiologic worsening of their state. And so you actually won't see this right away. You'll see it usually 24 to 48 hours after they've done too much activity. So it's important to be able to talk to your patients about what they're doing outside of rehab so you can get a bigger picture sense of what might have triggered this PEM. And you want to let them fully come back down to their baseline before you pick back up where you were. The third of the trio, mast cell activation syndrome, MCAS or MCAS. You will hear all of the above. And essentially what it is a chronic condition where your mast cells, so the cells that are responsible for your allergic reactions, are inconsistently triggered to inconsistent degrees. And so this is going to be the cell that releases things like histamine and other pro-inflammatory factors. So you may see things like flushing and itching and hives like you would for a typical allergic reaction. You could also see somebody has a lot of stomach trouble, or they present like they have a cold. You could see they have a lot of headaches or brain fog or things like that. It can affect their blood pressure, and it can actually look a lot like POTS. Or they could have anaphylaxis, and it could be that severe. But it can also be very severe in other ways, and it can be the missing key in our management. So as a rehab professional, what can we do about mast cell activation syndrome in the clinic? Well, there's a few things. First of all, we can help them avoid some of their triggers. And so that would be things like if they're allergic to latex, we replace the resistance bands. If they're bothered by the cleaner that we use, maybe we lay a sheet down on all the plinths before they come in, or whatever it may be that is one of their triggers, you help minimize that exposure. But no, you're right. We cannot change MCAS as a physical therapist or an occupational therapist, but it's very important that this is on our radar so we know when to refer out. And the reason I keep saying this is because it can present as vague pain and chronic inflammation. So you could be doing everything right in your rehabilitation strategies and you're not making progress. The reason that could be is because your mast cells are overactive and they're really fighting against you as you're trying to make progress with this patient. So you can refer them to somebody who can take a tryptase level or a histamine level or some of these other tests like an allergist or an immunologist that can help them get on the right slew of medications to really address their MCAS. That can be something like an H1 blocker, something like a Zyrtec, and an H2 blocker, so something like a Pepcid. H2 histamine receptors too are in your gut, and so that's why Pepcid is one of them as well. And then in addition to that H1 and H2 blocker, if you can get a mast cell stabilizer too, something like chromal and sodium, that pharmacologic approach might be game changing for these patients. So keeping it in mind, if you're really feeling like you're hitting a wall in PT and you don't know why they're still in so much pain and inflammation, recalling that the mast cells really could be fighting against you. And so the mast cells can play a role in some of the GI issues that you have in HEDS, but there are other issues that can cause a lot of trouble with GI. And again, this is something that is important for us to know so that we can refer out to the right providers and also so we can help put this whole picture together for our patients. It's also going to play a role in the positions we have available to work in. A lot of our patients aren't going to like being in a prone position because they have so much trouble with their stomach. Something like MALS, or median arcuate ligament syndrome, is where your median arcuate ligament strangles your celiac artery. And so that's going to make it very painful and difficult to eat. You're going to have painful bloating usually, and a lot of nausea and vomiting. People with MALS often have weight loss, don't always. And so one of the good questions that I use to screen for this is if a patient is telling me it's very painful to eat, I ask, hey, next time you try to eat, try and lean forward. And if you lean forward, see if that takes any of that pain away. And what that's doing in asking that question is it allows some of the pressure to come off of the celiac artery from the median arcuate ligament. And so that would be a good indication to refer out for a MALS diagnosis and allow your gastroenterologist to really address that. The other big player here is gastroparesis. And yes, it sounds like partial paralysis of the gastrointestinal system, and that's partially correct. It's a delayed gastric emptying. And so this really is a combination, in my opinion, of poor autonomic control and very stretchy GI systems that aren't giving the right feedback to move that food along. So now they're going to be bloated and have nausea and vomiting. They feel full very quickly, typically with gastroparesis. So this is another one you'd be referring out to GI, but keeping in mind there's other things too. These patients often have IBS, or the MCAS can be one of the triggers, and you might have some of those problems with the GI system. So now we're going to get into some of the neurological manifestations of HEDS. And so if you take a look here, you can use your smartphone and scan the QR code. It'll give you a differential diagnosis list. And across that list, you're going to see at the top, we have a bunch of diagnoses. And along the y-axis, we're going to have a number of symptoms. And so this chart breaks down the quality of several overlapping symptoms to help guide your differential diagnosis list. So it's going to really break down like the quality of the symptom to help you help direct this care. So for example, something on here is the headache. And so it's going to talk about how for CCI and AAI, which is what we're going to talk about next, is that upper cervical instability, they're going to have headaches quite often, but in the base of their skull. Whereas if someone has a Chiari malformation, they're probably going to have base of skull headaches too, but while one related to upper cervical spine might worsen with neck movements, one with Chiari might worsen with things that would change the intracranial pressure, so like coughing and sneezing, for example. So this whole chart is meant to help you, not to overwhelm you. Could not fit it on these slides for the life of me here, so that's why I'm giving you access to the chart itself, and I hope this helps during your treatment. But we are going to go into each of these neurologic manifestations here. So I really prefer to use the term upper cervical instabilities. And the reason I prefer UCI, or upper cervical instabilities, as my term is because I don't like being the one to call the difference between craniocervical instability and atlantoaxial instability. I think when somebody has one, there's a really good chance that they have both of these instabilities. So what are they? Craniocervical instability is the instability between the base of your skull and your first vertebrae. So that would be like your occiput to C1 or C0 to C1, if you will. And this is typically going to be worse with flexion and extension. The reason that is because your craniocervical junction is responsible for a lot of the flexion and extension that you do, especially capital, obviously, flexion and extension that you do. And so when you go to use this unstable joint, it provokes a lot of the symptoms. Whereas something like atlantoaxial instability, AAI, or Atlas and axis C1 on C2 is unstable, they're typically going to have more issues with rotation of the cervical spine. And that's because most of cervical rotation comes from C1 too. So as they turn their head to one side or the other, they're going to find a lot of their worsening symptoms if they have AAI. But like I said, there's a huge overlap. A lot of times if you've one, you might have both. One might be considerably worse than the other, but putting it on your radar that there's definitely a chance that somebody can have both CCI and AAI. Conventionally, for some reason, most people are referring to CCI. AAI is just as common, if not more, so don't be fooled by that common phrasing of CCI. Really, UCI is probably a better term for you. And so you will see on the chart that you probably have open alongside this video now, and it tells you a bunch of the signs and symptoms that go along with upper cervical instabilities. You're going to have maybe neck pain and headaches, dizziness, imbalance issues, brain fog. Really, if you think about it, if you have poor mechanics of the upper cervical spine, there's a good chance that you're putting pressure on the cervical medullary system. So you could have something called cervical medullary syndrome, and this would essentially be function of the medulla oblongata is now dysfunctional as well because of the mechanics of the pressure that you're putting on it from the upper cervical spine. So patients might have trouble sleeping, or they might feel like they're being choked or have trouble swallowing or speaking. So a good way to try and test this theory in the clinic is if you can try a brace trial. And so my preference is usually the Aspen Vista cervical collar. That's the one pictured above the words signs and symptoms over here. And that Aspen Vista has the little yellow knob in the front. You pull that out and you twist it and it gets higher or lower. So it's very adjustable. The straps on the side are very long, so you can make it as loose or tight as you need to. Some patients do need a little extra support. So if you can fold up something very flat and reliable beneath their occiput, sometimes that can fill an uncomfortable gap in that brace. But I really prefer the Aspen Vista most of the time. But that said, the Miami J is another good brace. It is a little bit adjustable, not quite as adjustable as the Aspen Vista. The Miami J they sell multiple sizes. If you go on their website, it'll give you all the resources for sizing a Miami J appropriately. And the reason I bring this one up is because it is so common to have jaw issues or TMJ dysfunction with this population. This one cradles the TMJ a bit better. So if your patient has upper cervical instabilities and TMJ dysfunction, I might refer you over to the Miami J instead. So we will talk about a lot of the interventions you can do with someone with upper cervical instabilities, but what I do need to make very clear here is that we want to treat them conservatively as much as we can. Yes, fusions are out there and they are amazing for the people who need them, but they have a lot of unwanted downstream effects and it's quite a risky surgery. So if you can avoid the fusion, you want to. I'm going to say that again for the people in the back. If you can avoid the cervical fusion surgery, you want to. But it is also a helpful resource or a helpful tool for people who have unsafe instability and in some cases are warranted. And I say this with such intensity because a lot of people find that they're on, one of two sides of this. Everybody should get a fusion that has this, or nobody should have a fusion that has this. And neither of those statements are true. There are plenty of people where it's what you need to do, and there's plenty of people who have this and can safely live with the right tools and rehabilitative techniques. So what you're going to want to do with a lot of these upper cervical instability patients has a lot to do with the rest of their presentation, and we're going to get into that when we talk about some interventions. To test for it in the clinic, we're going to use an alar ligament stress test and a sharp pursor test. And I am going to upload some videos on this channel so that you have access as to how to do those tests. But for now, we're going to talk about some of the specialized imaging that you should do so that you can get a sense if a patient has these upper cervical instabilities. At this point, you should already have done an upper motor neuron screen and an upper quarter screen, so you can really check to see how the neurologic system is working and if their neck is impacting other symptoms. So we'll refer out for an upright flexion and extension MRI for CCI. I mean, you can catch AAI on that as well, but this one, since it's flexion extension, is going to be very, very relevant for CCI. And then a rotational CT scan, same thing. You might see a bit of your CCI troubles on a rotational CT scan, but because we're doing rotation, this is going to have a lot to do with the diagnosis for AAI. And so there's some special measures you have to add in for that upright flexion and extension MRI. They will be seated in a upright MRI machine. Basically, it looks like you have two very close walls to you. You're seated in a seat. You're not in a tube. You're not lying down. You will find these local to you. A lot of times you have to look for one that's made for people with claustrophobia. It's the same machine. So you'll want to get a clevo-axial angle added to your upright flexion and extension MRI. So your clivus is the triangular shaped bone at the base of your skull, and your axis is your C1. So you're going to look at the angle that the bottom of your clivus, or posterior aspect of your clivus and your axis make together. And if that's less than 135 degrees, that would be indicative of some craniocervical instability. Then we have the Grab-Oaks measure. That's also looking at the clivus. This one is at the bottom, so the basion of your clivus, and it's looking at the posterior aspect. So you're drawing a line from your basion, the bottom of your clivus, to the posterior aspect of C2. And in that line, you're going to see if that distance to the dura is greater than 9 millimeters. If it is, that would be a positive sign for craniocervical instability. And finally, I know we aren't techs for reading these images, but it's helpful so that you know what you're looking for to get these tests done, is the horizontal Harris line. And so the horizontal Harris line is looking at the distance. It's a straight vertical line from the posterior border of the level of the axis to the basion, and we assess that difference. We're looking for 12 millimeters if it's CCI, or if there's more than a 2 millimeter change between flexion and extension. I find the rotational CT scan much more straightforward to understand as a rehab professional. So essentially, if they rotate, you're going to have them in a regular CT machine. You can do this at any CT scan center. You'll have them look all the way to one side, look forward, and all the way to the other, and you're going to compare those images. And what we're looking for is the facet overlap between C1 and C2, and how much of a loss of contact we get as those patients turn their heads. So those are your tests for upper cervical instability. Alongside upper cervical instabilities, you can also have Chiari malformations. You can have them on their own as well. There are different types of Chiari malformations, and what we're looking at here is if the cerebellum is herniating through the foramen magnum at all. And so these are going to also cause a lot of headaches, also at the base of the skull, but this one's going to have a lot to do with dizziness and balance issues, a lot of straining kind of pain. You're going to find that people with Chiari a lot of times are going to feel a lot worse with like laughing, coughing, crying, sneezing, pushing, yelling, going up the stairs. Things that would increase their intracranial pressure will probably increase that base of skull pain. So that's what you're looking out for a Chiari malformation. And that's another referral out to neurology, just like the upper cervical instability is. Another neurologic condition where we're referring to neurology if we think that this is relevant is tethered cord syndrome. This is very much so tied to Chiari as well, because tethered cord syndrome is where your spinal cord is overly tethered. And so that downward force can really pull on everything, including your brain, and causing that herniation of the cerebellum. So tethered cord might be the reason why somebody has a Chiari malformation. Tethered cord could be changing the mechanics at the upper cervical spine as it's over anchored. And so classically, classically, tethered cord is going to present in babies outside of the hypermobile population. That's when you hear about TCS. But in EDS and these hypermobile conditions, we're finding an adult onset around 20 years of age or a little bit older. That's typically where we're seeing patients become symptomatic. And what you can look for in the clinic is a sacral dimple. It can either literally be indented or it'll look like a birthmark. You can see it's pictured down here. And so that'll be just above the gluteal cleft. And then you're also going to have a lot of back pain and leg weakness. It might not always be weak. It might come and go and symptoms can fluctuate. It might be positional dependent. These patients are often worse with their legs straight. So they might tell you, I can't stand still in one position. My legs tend to go weak. I can't sit and long sit on the couch. I can't lay down with my legs straight. All of these things are triggers it shoots to my back pain. It makes my legs feel worse. Those are things you might hear with tethered cord. You can get an MRI of the lumbar spine to take a look for this. That said, you won't always see something. That would be occult tethered cord, is when you have tethered cord, no radiologic findings of it. But you might find that it's a low-lying conus medullaris, or you might find a tight filum terminale there. So another good way to test for this that's a bit more reliable, since we're probably going to have an occult tethered cord picture here, is a urodynamic test. And so that's going to take a look if we have a neurogenic bladder, because in tethered cord, there's so frequently a neurogenic bladder with bowel and bladder changes. So if you have something like that positive urinalysis test and a sacral dimple, those are going to point to positive signs for tethered cord syndrome. There's some other things you can look for. They might have foot deformities. They might feel like certain muscle groups shut off at certain times, and those would all be signs to point towards a tethered cord. Another issue we can have in the hypermobile population in regards to our neurologic manifestations are cerebrospinal fluid leaks, or CSF leaks. And this is very interesting in this population because you can have a tear in the dura and that would cause a CSF leak. And that can happen quite easily because of the poor connective tissue, the poor quality of the tissue that's lining where the cerebrospinal fluid should be circulating. But on the other hand, like I said with the pyogenic papules, ironically, something so harmless and then something that can be so serious. But similarly, you're going to have that porous connective tissue. That porous nature is going to allow for some fluid to seep out without even a tear. So this is going to be an interesting one to look out. If patients have discharge of the nose or the ears, that would be immediate referral for a CSF leak. But a lot of times it's not quite so clear. A good test for CSF leaks is if they have immediate changes upon positional changes. That would lead you more into the direction of a CSF leak. Now, wouldn't POTS also have a positional change? Wouldn't resting your cervical spine also have a change? Yes, absolutely, you are right. These things will have changes. A lot of these patients feel better when they're laying down anyway. But in a CSF leak, you will have an immediate change, whereas the others will take some time to get back to baseline. Depending on where the tear is, whether it is cranial or non-cranial, will be whether it immediately worsens or immediately improves upon being supine. But that immediate change should be what clues you in to be looking for a CSF leak and refer out for neurology again. Another referral for neurology is in idiopathic intracranial hypertension, or IIH. And you'll also hear the patients a lot of times really like the term pseudotumor cerebri because it's a little bit easier to say. But I do want to clarify there is no tumor. It's called pseudotumor because the space that the pressure and the fluid takes up would mimic a tumor, but there's no tumor present. So IIH is characterized by elevated pressure inside of the skull without an apparent cause. What you're going to see upon evaluation of these patients with your imaging, a lot of times they have an empty cella. So no, you cannot see IIH on imaging, but I still do refer out for an MRI, cranial MRI, so that I can get a sense if they have the empty cella and they're presenting with signs and symptoms of IIH, we refer out again. And we refer out with concerns for IIH. We want to catch IIH quickly because this one, it puts pressure on your optic nerve. So one of the symptoms that does set this apart is that they might have visual snow or a lot of other visual disturbances, constant headaches. They might have tinnitus and nausea, things of that nature. But we want to make sure that we are getting this referral out and addressing the IIH so that we don't have permanent changes to the vision or vision loss. If your patient is overweight, this is not the cause. It is not the cause of IIH, but weight loss can help. Otherwise, we would shunt for something like this. There are a couple other neuro nodes I wanted to touch base on. It would be neuropathies. And so we can have both peripheral or small fiber neuropathies. Some of the peripheral neuropathies are things like numbness, tingling, weakness, and pain, things like that. But keeping in mind, you can also have some nerve damage as a result of your hypermobility. If you keep subluxating your shoulder, per se, if that's the example we want to take here, you can hit your neurovascular structures. That includes your nerves. And so when you do that, you can get some of the tingling and the numbness that you would get in your hands. So making sure that we are correcting subluxations the right way in a safe way and communicating with our patients so that we minimize any nerve damage from subluxations or dislocations. A small fiber neuropathy is more related to that dysautonomia we already talked about. Also keeping in mind neurodivergence. This is very big in this population. People with HEDS or any hypermobile spectrum disorder, this is going to impact females more commonly than males. Well, ASD, autism spectrum disorder, is much more difficult to diagnose in females than it is in males. So you may have a high prevalence of patients with undiagnosed autism spectrum disorder, or maybe they are diagnosed. It's not exclusive to ASD. It's also common to see ADHD and OCD in the presence of hypermobile Ehlers-Danlos syndrome and other connective tissue disorders. So please have some patience with your patients as they are navigating these things to the best of their abilities and may need your support. So we're getting into the good stuff, the overview of exercise interventions in PT. There are several different goals we want to address when we're talking about treating the hypermobile patient. And so for the first bullet point on here, I have multitasking ability and this mindless endurance. So what do I mean when I'm talking about mindless endurance? We are going to redirect from working on big, strong muscles where, like, a lot of people, if they go to a strengthening class or they're working out on their own, they're going to do a lot of the muscles that are good for show. That is not necessarily going to translate to the same ones that are good for stability. A lot of times stability muscles are your smaller muscles. So for example, I keep using the shoulder, the rotator cuff is when you're not going to see much of a result from strengthening your rotator cuff, but that's going to be the most impactful for your joint stability. And so we're going to attack these stabilizer muscles to have this mindless endurance. And I'm circling back to that phrase. And so mindless endurance is that we want them to be able to have that on all day long. Why? Because we have a passive subsystem and an active subsystem. And in our active subsystem, we have the muscles. In our passive subsystem, we have our ligaments. And the passive subsystem, referring to those ligaments in somebody with hypermobility, is not functional. So it's not providing a lot of support. So you don't have much of the passive subsystem. You do have your active subsystem, but it's not meant to be on all day. It's supposed to be supported by that passive side. And so now we have to retrain the body to be okay with having your active subsystem really step in and replace that passive subsystem. And I take the time to explain this to all of my patients. I also tell them, there's a lot more that makes up connective tissue than just these two factors. But if we break it down in simple terms, we have collagen and we have elastin. And collagen should be the rope-like structure that holds everything together. And elastin is like the rubber bands that kind of let you have a little bit more give to your joints in a typical population. Now, with someone with a connective tissue disorder, imagine that the rope is fraying and breaking apart and it's unreliable. It's untwisting, it's not very useful. So you're going to rely on the rubber bands, the elastin. And so now that passive subsystem really is going to do less for you than the active subsystem will do if you train it correctly. So we need the active subsystem to be able to be on all the time, supporting these joints. And we also need to be able to have it on while they are conducting their daily life. So I need my patient to be able to have a conversation with whoever's in the kitchen with them as they're reaching overhead, not even looking what they're doing, grabbing a bowl. But I need the concavity compression mechanism that turns on when you strengthen your rotator cuff muscles for that stability without them even thinking about it. And so this is where there's a big difference between, okay, yes, your biceps do cross the shoulder joint. And so maybe somebody is using their biceps for some of their shoulder stability. Well, that's on the anterior aspect of your arm. That's really going to pull you into an anterior subluxation if you over rely on a muscle like that. Or you use your upper traps and you're going to be very hypertonic in your trapezius, which is a painful place to be. Hypertonics give you headaches and all these other consequences from using these muscles, and they're not made for stability. So it's A, not going to do it correctly, B, going to pull you into other issues. And C, it's very fatiguing to use your large joints not intended for stability for stability. So you want to re-educate your patients to stop using their larger muscle groups for stability and start using those small stabilizers in a mindless way. And so that is where we do low loads and high reps in the beginning to really work on that endurance. But it's all day endurance, like I said. So this is really going to a place that's much higher level of endurance that is your typical goal in an orthopedic setting. So we're going for higher than average endurance, and then we're going to add in distractions. So instead of, if an exercise gets very easy, instead of throwing it out and moving on to something more difficult, maybe what we do is we combine that exercise with another one that's been getting easy, and we make them multitask, or we add in distractions, or we add in perturbations to make this a lot more of a functional intervention so that this stability can become something that's second nature to them. Added twist, they also have poor proprioception. So that's going to make the first bullet point of what I've already talked about much more difficult to attain. Why do we have poor proprioception in connective tissue disorder? That's because your proprioception is often coming from your Golgi tendon organs and your muscle spindles. And those two things rely on this stretch feedback when things get to their end range for that feedback. And so I explain proprioception to my patients in the literal sense. If I close my eyes and I put my arm behind my back, I know my arm is behind my back. I know where my hand is in space. Ours isn't always that bad, but there is poor proprioception, so this is going to impair balance. This is going to make us at risk for falls. This is going to make a clumsy bunch that it has poor joint mechanics, usually poor posture as well. And so this is another tidbit for your evaluation. When you're talking to your patient and you see they're fidgeting around, that's a sign of that poor proprioception. And so you can talk to them, hey, I see you're fidgeting a lot. Is that something you do often? And when they inevitably tell you that they do, you can say, yes. So what that is your body is searching for that proprioceptive feedback. And a lot of times they'll be amazed that you already knew when you ask the question, do you walk into doorways a lot? And do you hit the corner of tables and you can't quite sit still? How'd you know all of that? And that's because that poor proprioception is so characteristic of this hypermobile tissue. And so, like I said, we're moving, we're fidgeting, we're putting our joints at end range. You're going to see patients, they're the ones who put their foot on the dashboard, and they're the ones who have one leg down and one leg up when they're sitting at work, or they're sitting in pretzel style no matter where they're sitting, or if their legs are down, maybe their ankle is turned all the way in and it's on the ground. And so the reason we're looking to untrain this habit is because ligaments do stretch and they don't recoil. So while EDS may or may not be a progressive disorder, if you continue stretching your ligaments, it will feel progressive. So we want to retrain them to find that neutral position and find a way to maintain comfort in those positions as well. It's also going to play a huge role in added interventions that you're going to be doing, as well as watching for mechanics as you're doing the interventions that you'd like to. We also need to keep in mind subluxations, and we're going to go through some subluxations in this PowerPoint, and then I'm going to upload a few other videos for how to detect and correct some other subluxations as well. But really anything can sublux, so you do want to make sure you're keeping an eye for those subluxations because we don't want to work with our body out of alignment. So we want to address those things as well as the comorbidities. We're also going to be limited by what positions some of the patients tolerate because of either their upright tolerance from the dysautonomia and the POTS, or because of other issues of other parts of the body. You may be trying to work on the hip, but if it involves weight bearing through the shoulder, that could be an issue for that reason. Or they might not be able to be in prone because of their stomach. So keeping in mind those comorbidities as well. And then the biggest part that I can't stress enough is validation. Make sure you are validating your patients. You tell them explicitly, I do not think you're crazy. This is not in your head. I believe you, and these things are real. The reason you're having trouble with this, and give them the patient education. Knowledge is power. And when you can give someone the education to understand what's happening with their body, and remember, they know their body best. When you pair it with that education and that knowledge, it allows the nervous system to calm down. It has a physiologic response for their nervous system to turn some of the alarms off when it's not a big question and when they understand why these things are happening. So don't just treat your patient blindly. Make sure you're walking them through, this is why this happens. It's real and you're not making up, and here's how we're going to address it, and here's why. So to get into some of the way we address these patients is we have to start at the feet. In a lot of these cases, the feet is the foundation. And so stability does work from the ground up. I have a picture of Jenga here because if you try and build a Jenga tower on the edge of a fluffy couch, you're not getting anywhere. And if you do, and you pull one little thing out, the whole thing's going to crumble because you have a bad foundation. So that's why we want to make sure we are addressing the feet, as that biomechanical collapse of the arch can have widespread effects. So you can see in the picture here that upon weight bearing, or upon non-weight bearing, they may have an arch, and then when they go to stand, it falls flat. It's a similar concept of the princess and the pea. There's one thing wrong at the very, very bottom, and no matter how much you add and you try and cushion, it still is going to affect all the way up to the princess, right? And the princess and the pea. And so similarly, in the kinematic chain, we have this concept of regional interdependence. And so I'm going to follow along for a minute with this collapsed arch example. So if you take a look at this picture of the kinematic chain, let's say you have a collapsed arch. And so now that you have that flexible flat foot, when you go to stand, now you might fall into some calcaneal valgus. That calcaneal valgus is going to make your ankle more unstable. As your ankle is more unstable and you fall into that calcaneal valgus, out of reflex, you're most likely going to shoot your knee backwards into hyperextension. So when you have that genu recuvatum, it's going to inhibit the quads and the hamstrings. And so now that your quadriceps and your hamstrings are doing very little during gait, you're going to flop your leg out into hyperextension with each step. Now that that isn't turning on, you're going to find yourself in a lot of pelvic obliquities, probably 3 to be exact. We're going to talk about the different planes of the pelvic obliquities that can happen, but nonetheless, when you have this malalignment, it's going to tilt the base of your pelvis. Now your pelvis is going to feed into your spine. You have an unstable start or a tilted start to your spine, and you're going to have a scoliotic posture, whether you do have scoliosis, which is very possible in this population, or this is worsening and exaggerating the scoliosis that matters for spinal neutrality for a lot of reasons, but also because as you have a scoliotic curve, one of your shoulders is going to be lower than the other. As it is, it's tilted towards gravity or towards the ground, and gravity can really predispose that shoulder to more instability, pull that out of the joint a little bit, pull it out of alignment. Now your cervical muscles are strained because your shoulder's out of place. Or even without that, it still can affect the cervical spine because as you are tilted at the top, you have to tilt your head so that you maintain eye level. And so that upper cervical tilt is really going to be important for that upper cervical instability. So you can see how I'm talking about a flat foot can impact upper cervical spine and everything in between. So we have to strengthen the foot. We want to do some foot doming activity. We're going to work on the forefoot. We're going to work on the intrinsic, and we're going to be able to add this as one of our distractions. One of our multitasking activities during other interventions might be holding an arch or doing something else with the feet to keep them active. But the feet, I do not see as the only foundation. I also see the pelvis as the keystone to the body. And so if you see here, it's like a picture of a real keystone. That is because if you take that keystone out, everything above and below it's going to collapse. And similarly with the pelvis, as we talked about in that example of regional interdependence, when that keystone is malaligned, everything below it, so your lower extremities will be altered, and so will everything above. And so that's why it's important to talk about the pelvis. You can have obliquities in the sagittal plane, transverse plane, and frontal plane, and that would include an ilium rotation, flare, and upslip. And I usually show this to patients with my fingers. And so I make a little ring with my fingers in front of them. I tell them that my fingernail is like the bone that I'm assessing when I'm looking for their pelvic obliquities. So in our terms, the fingernails in this little ring that you make with your fingers are the anterior superior iliac spines, or the ASISs. And so it should be a stable ring. If you have an ilium rotation, you'll tilt one of your hands backward. That will be what that rotates. And when you do that, you see that the ASIS on that side becomes higher than the other. Or conversely, if the other side anteriorly rotates, it's still going to look the same. You're still going to have one side higher and one side lower. And so what's great about the way that we address these ilium rotations is that we use a muscle energy technique that we work on bilaterally so that it's okay whether it was an anterior rotation of one side or a posterior rotation of the other. In the transverse plane, we can have flares. So again, if we use our little finger model to explain this to patients, we have our ring made up in front of them as a stable ring. It can tilt outwardly, and that would be an out flare, or it can tilt inwardly, and that would be an in flare. So then we can also have an upslip. That would be if you take that stable ring and you move one of your hands up. So what a lot of patients do, unknowingly, of course, is that they will have multiple of these. It's their body's way to try to accommodate to get a stable base again. So if you take your fingers in front of you and you have your front fingernail acting like your ASIS, then if you have a rotation, so let's do a posterior rotation of our right ilium. So I'm tilting my right hand backwards. Now I can see that that right ASIS is elevated, the PSIS is depressed. That would be my thumb on the back of my little finger ring here. Then in response, maybe on the left side, I go into an out flare. We're getting closer to a stable ring now. As we tilt that hand away or that ilium away, it looks more like a stable ring, especially what if we do an upslip on that left side too? And then we do an in flare on the right side. Do you see how we've created a stable ring with our fingers, but it's crooked? And so that's the way the body a lot of times is going to accommodate, is to add more of these obliquities, but really it's worsening our starting state for our spine because our pelvis is really where the spine is situated. And so I want to talk about how you assess these things and how you correct them. This is very, very important to do in the clinic and to teach the patient and their family. So I'll bring families in for family education sessions for something like this. I am doing this on most sessions. So I do not correct all subluxations on every session, but the pelvis is one that I will typically correct. And I'm also looking at the pelvis in cases where it doesn't seem like I should. So if somebody's coming in for an upper cervical instability evaluation, or maybe it's not even upper cervical instability, maybe it's just neck pain, or maybe they have a lot of shoulder pain, I'm checking the pelvis. And that sounds unrelated, but when you think about the fact that they'll never reach a spinal neutral position if they have an unstable pelvis, that's why it's so relevant for these other joints. And so because of that regional interdependence, I would say the pelvis is typically going to be something at least worth checking, and if out of alignment, worth correcting and teaching the patient how to, so that you can regularly work in spinal neutrality. So here's a video on evaluating and correcting these malalignments. When assessing for an ilium rotation, you're going to have the patient in supine, and then you're going to palpate their anterior superior iliac spine, or that bony, pointy part of the pelvis that sticks out in the front. As you can see here that my thumbs are not even, her right side was much higher than her left side shown here. That shows me that she either had a posterior rotation of the right side or an anterior rotation of the left side. Either way, the correction is the same. You can see here that the patient is performing the muscle energy technique to correct for that. So the side that was higher comes higher is my trick to remember. So she's isometrically using her flexors on the posteriorly rotated side and her extensors on the anteriorly rotated side. And as you can see, she did 6 seconds 5 times, and that has been corrected. I now have the patient in short sit to assess for an upslip. I come behind her, I come in the small of her waist, I go inwards and drop down until I land atop her pelvis. As you can see, I'm landing atop her pelvis. My right hand is higher than the left hand. This shows that the patient has an upslip. The way that you correct for an upslip is to have the patient lie on their side with the upslip side on top, and then the PT will come in and mobilize that affected ilium. To do so, you'll put your hand from their ASIS and wrap as much back as you can around the pelvis, and then puzzle your other hand on that posterior bulk of the pelvis. As you can see, I'm giving an inferiorly directed force to the pelvis. I take up the slack a couple of times with a lower grade mobilization. And note, when I say inferior, I mean down towards her feet, not down into the table. So I go for a couple lower grade and then a quick high grade mobilization inferiorly to the pelvis. Usually I do 3 to 5 low grades in between my 3 to 5 larger grades, but I can repeat this as necessary until the upslip is corrected. So upon finishing this, you'll have the patient sit back up, do that same test with your hands landing atop the pelvis, and assess if there is still an upslip. Finally, you want the patient in supine, and you will have their heels on the table so that you can assess if there's an inflare or an outflare of the pelvis. What you're going to do here is to assess the range of motion on either side. Don't move via the ankle because that's probably hypermobile as well. So move via the hip and check that external rotation on both sides and see if it is even. You can see here that her left side makes it closer to the table than the right. Since her right leg is limited into external rotation, that would be indicative of an outflare of that side of the pelvis. To correct for this, she will act isometrically into my own force. I have one hand stabilizing at the pelvis just for comfort, and the other hand is resisting her external rotation force here. So she will repeat 6 seconds, 5 times into my hand. You can see here the patient does have some miscellaneous recruitment. I am more worried about the force than the form. However, I should have corrected the form in this patient. For time's sake, I won't show you all of the repetitions here, but upon finishing, do have the patient in the beginning position and reassess. To assess for an inflare, you'll have the patient in supine with heels on the table again, feet far enough so that the leg is not limited into its internal rotation. So you'll assess by bringing the hip into internal rotation. Don't move via the foot again for the ankle's sake. And as you can see here, she's more limited on the left than she is on the right. That will show us that she has an inflare on the left side. You'll have her go into semi-hook lying position once again. It'll be corrected with another isometric. The patient will be pulling into internal rotation to correct for the inflare because she was limited into internal rotation. Same count where we go for 6 seconds, 5 repetitions, and upon finishing, have the patient back in the beginning position and reassess. So that is what we're looking to do when we are addressing the multiplanar pelvic instability. The other big ticket item when we're talking about subluxations is the shoulder. The shoulder can subluxate in any direction. Do keep that in mind. But the most common by far is in the anterior direction. And so when that happens, we do want to be mindful of how many times we are correcting this. I do try to address the shoulder. Usually I try in the beginning of a visit to ensure that we're exercising with our shoulders in good position. But if this is something that keeps happening, it keeps subluxating throughout the visit, you can correct it, but be mindful of how many times you are doing this technique, because as you continue to give that posterior force to correct this, it can cause a bit of irritation and inflammation. So this and other subluxations, keep in mind your pacing of how often you do this so you're not running them into an inflammatory cycle. I do have another video here so that you can see how to correct a subluxated shoulder. In order to assess if a patient has a subluxated shoulder, you'll want to palpate medially to the humeral head and move out laterally. Of course, in any shoulder, you will feel a little bit of rounding, but in a subluxated shoulder, you'll feel an anteriorly pushed forward humeral head where your thumb significantly jumps up. You'll want to have the patient lie down in supine to correct it. You'll take the arm out to somewhere between 45 to 90 degrees of abduction and give them slight axial tension. With your contralateral hand, you will go ahead and give a posteriorly directed force, just one, sustained, and then let go. Let go of the axial tension, put the arm back by the side, and reassess. And this is where you can really tell what it should look like, where you can see I can still feel the rounding, of course, of the humeral head, but not punched forward. This one's a little bit nuanced because as I say axial distraction, I want to make it clear this is not a heavy force. They're hypermobile, so they don't need a lot of force for you to get that axial distraction. The reason why you need it is so that you can go around the labrum, so you're not pushing directly into the labrum every single time that you help reseat this position of the glenohumeral joint. But when it's subluxated, especially anteriorly, there's a really good chance you are sitting on the labrum, and that's actually what's generating a lot of the pain. And so when you give that little bit of axial distraction, it allows you to get off that labrum and back into the glenoid fossa. So it gives you a little bit of a better seating position with a little bit less pain. Just don't pull too hard. They really don't need that much distraction. They're hypermobile. You can definitely cause them harm by doing that with too much force. So be gentle with that axial distraction. You'll also know at the top of these slides, it says for the providers, I want you guys to get comfortable with doing these things first, and then we can talk about how to educate the family to do this at home if it's something that you're comfortable with. I also want to address that this is going to really affect everywhere in the body. Those are the two main subluxations that I do from visit to visit because I feel that they feed into the regional interdependence theory so heavily. But anything can subluxate. And I know this picture is here, like it was made to be funny and it's on stickers and people have it on shirts, but it's actually pretty true, right? It's everything that we've already talked about. When you have one thing wrong, it's going to lead to the other. You can see in the picture of your body with Ehlers-Danlos syndrome, the skeleton has a tilted pelvis, and you can see how the one hip is jammed into the pelvis and the other hip is kind of falling out, how that impacts the knees and the ankles aren't straight, how they didn't draw the spine curving, but the spine would curve. That would impact the ribs and then the shoulders, and the shoulders can go down that kinematic chain of the arm, and the head is tilted. So you can see between the poor proprioception and the regional interdependence, there's a lot of things that can be in a poor articulation here. And so it is much more common to have a subluxation than a dislocation in Ehlers-Danlos syndrome. And no, it's actually not within the scope of a physical therapist to correct a dislocation. But more times than not, it's a subluxation. And I see subluxations on a scale from 0% would be that you don't have a subluxation, 100% would be a dislocation. So from 1 to 99% of poor placement of the position is a subluxation. And that's something that really matters and that we can help with. And so we want to address the RIPPY cycle. The RIPPY cycle is the regional interdependence poor proprioceptive input cycle. And you can pause the video here if the words are what's most helpful to you. But I'm actually going to explain it with the picture on the screen here. And so the RIPPY cycle it feeds into itself as it's a cycle. And I'm going to pick an example to explain this with because I find it more helpful to learn something alongside its example. So let's say T8 is hypermobile. It's a bit unstable in your thoracic spine. So if you have hypermobility of T8, so we're in that section 1 on this cycle, you have that hypermobility, you're going to keep using it. That's leading into section 2 already. So we're in the second phase of the RIPPY cycle. You're unintentionally using this extra range of motion because you don't realize you're doing it. You have poor proprioception and you have that extra range. It feels natural to you. So moving into segment 3 of the RIPPY cycle here, you no longer depend on those neighboring segments because T8 can do all the work. If T8 can move and move and move, then you would never need your T7 or your T9 to do much of the movement. We lose some of that segmental control and we begin hinging at that hypermobile or unstable joint. And so now, leading into part 4 of the RIPPY cycle, that poor proprioception really reinforces this movement pattern because we don't know we're doing anything wrong. So as these patients continue to use T8, 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 they don't need to use the rest of their spine like we said in part 3. They have no idea. This becomes their regular movement pattern. Moving into part 5 of the RIPPY cycle, now that it's become a regular part of their movement pattern, they're going to have musculotendinous shortening in the areas around it from disuse. You're not using T7, you're not using T9. So these things are going to lock up with the segments above and below because they're not really needed to segmentally move very much. They're going to become more difficult to move. And as they become more difficult to move, your T6-7 doesn't move very naturally because it's cut and tight from disuse. Your T8's only going to move more. And so that shortening is going to be very painful alongside hypermobility. That mismatch is a very painful experience for these patients. Not to mention, as you become more hypermobile and more unstable from this very cycle, so getting back into 1, now we're going to combine it with these muscles are going to try and lock up and have high tone and spasticity to try and prevent further instability. And this is where a lot of times they start coming in to see you is because of this mismatch and this pain that they have. And so that's where the RIPPY cycle becomes really a basis for all of what we're treating. And so the first example that I have on the slide here is the spine, and that's exactly what we just talked about. You're going to keep hinging at that hypermobile segment. You'll lose some of those other range of motions in the surrounding area. You stop using your spine segmentally and you start just hinging. This is retrainable. We're going to talk about that in a moment, but I want to point out some other places where you're going to see the RIPPY cycle emerge. Things like the knees. And actually, we talked about this already. We said about when the arch collapses and all the things the ankles will do, and then the knees, and that'll cause inhibition of the quadriceps and of the hamstring. And so as you have these inhibitions of these muscles, you're going to go into hyperextension in your gait naturally. And so that's another place where it's truly the Rippy cycle. You're hypermobile one place, so that poor proprioception feeds into this cycle of continuing that movement pattern and the muscles adapting to this new movement pattern that becomes your new norm. And so that's how it can affect the knees. It can also affect in thoracic outlet syndrome. It's actually fairly common in the hypermobile population. And the reason that may be is because as your glenohumeral joint can move so much, it doesn't really need a scapulohumeral rhythm. So if you don't use your scapula to move your glenohumeral joint because it has so much range on its own, doesn't need to, you're really going to compromise your thoracic outlet, and then you're going to compromise the structures that are trying to exit through that vital space. So we want to make sure patients are moving their scapula with their glenohumeral elevation and all of the movements, all of the range of motion that you do have of your glenohumeral joint, so that we're not closing down other spaces. So even though they don't need to reach as high as they want to, because they have that range of motion available to them, we want to retrain them to have that good movement pattern, which is tough to do when you have poor proprioception, so that we're not locking down those other places as we would in thoracic outlet syndrome. And then the cervical spine I have listed on here as well. It's very similar to, we already talked about the spine, it's all part of the spine here. And as we have upper cervical instability issues with some of our patients, keep in mind how much motion really occurs at the upper cervical spine. So if that becomes unstable and hypermobile, we're not going to use the rest of our spine. And we feed into that movement pattern, we lock down the other segments, we create a reliance on this hypermobility, and it progresses to instability. How do we break the Rippy cycle? We need other cues. Tactile is helpful. We also need visual cues. I found with my patients the visual cues are extremely helpful. So I use mirrors a lot. I use lasers and videos, and then we break down a larger activity into its smaller pieces and keep doing that until that becomes normal, and we add it back into the larger scale task. So I think that the lasers are actually very helpful in this population. So let me continue with that upper cervical spine example I just closed with on some of the examples we have for the Rippy cycle. So say somebody's very hypermobile in their upper cervical spine, then you're going to have, you can put a laser on their forehead, and you can put a target ahead of them, and you can have them try and just stay on that target. Some patients with their proprioception and their lack of spinal stability and unable to sit still are going to have trouble doing that alone. But then you can progress that. You can keep the target ahead, have them move their head to the side and come back and find the target, move their head to the other side and find the target. Not easy. You can progress that by having the target maintain where it is, still have the laser on their head, they're focusing on the target, move their head to one side with the eyes closed, and come back, try and find the target with the eyes closed. As they do that, there's probably some mismatch. Have them open the eyes and try and correct the difference. You can do the same thing to the other side. You can do it going up and down as well. So there's a lot of different things you can do with the laser. You can also have them just keep steady on that target and move different parts of their body and test their proprioception in that regard. So maybe their upper cervical spine is so hypermobile, they're having a hard time holding still even when they move one of their arms. So you can hold that stable target practice with the laser on the head while you either move the arms or you move the legs or you move both arms together, whatever it may be. You see where I'm going with this. You can also use it for other applications. You can put it on the foot and get a maze and go for inversion and eversion of the foot to try and work on some of that proprioception. But essentially, my point of saying all this is that when you break the Rippy cycle, which is an essential part of your rehabilitative techniques with your patients with hypermobility, you need to train their proprioception, and you need to be aware of that regional interdependence and all of the other things that can affect what you're trying to look at. So you also, in addition to all of those things, need to address the hypertonic muscles. And this can be a controversy in this population. Sometimes people say, well, the tight muscles is all that's holding them together. You just told me their passive subsystem is so faulty. How am I going to release their active subsystem on them? So you do need to balance it with a bit of stabilization at the same time that you're releasing some of that tension. But I would recommend doing some IISTM, some instrument-assisted soft tissue massage. You can carefully do some cupping to the tissue. You can do a number of things to really get that hypertonic muscle to calm down. But another essential piece to this is having the patients responsible for some of that relaxation technique. So really being able to have deep breaths and do breath work, box breathing, diaphragmatic breathing, and doing these things and having them try to relax these muscles is going to be key for being able to break the rippy cycle. But of course, that's not the only thing that we do with this population. There are a number of interventions. You can get very creative with this population. And I know that you guys have your own interventions, so I won't waste your time in reading all of these out, but there are some good ones that I want to point out. For example, the deep neck flexors are going to be key for stabilizing in the cervical spine. So a good way to teach a patient what that should feel like is actually if you put the tongue to the roof of the mouth, you will feel your deep neck flexors activate. And so that's a good way to retrain it. It's even a good way to gently start with your training for it. Hold that contraction for some time. We're doing a lot of isometrics with this patient population, so that's an isometric in itself, and you can begin there for some of these patients. As you get a bit more stable in the cervical spine, you can do some other exercises. I have a head harness pictured here. You have to wait until you're pretty darn stable to add something like this in there, but you can clip this onto their head. You can add some bands into the clips, and either you can pull, or you can have you're standing still, or you can hook it onto something on the wall or your cable column and have them take steps away from the resistance. Their head's going to want to tilt towards that resistance. But if you strictly tell them they need to keep it stable and neutral, give them a visual feedback, maybe record them or give them a mirror, then they're going to be responsible for holding that cranial neutral position. And that's so functional and so key. And I tend to keep everything very functional with this population. So functional and multitasking, a lot of isometrics. Another example of that would be similarly, if you have the resistance fixed at a certain point, you have your patient take a few steps away with their arm in a 90-90 position. The resistance may be trying to pull them into external rotation, or conversely, you can have it coming from the other side and trying to pull them into internal rotation. So they're fighting that with an isometric, and make it dynamic, make them have to either move around or make them have to step up on a Bosu ball, and it challenges their balance and their ankle stability and their ankle strategies of their balance and things like that. So I'm going to leave this here. You're welcome to pause and steal whatever interventions you'd like. You're welcome to be creative. We are not looking to necessarily stretch these patients. I'm not saying there's never an indication for that. We're not looking to stretch joints pretty much ever in this population, but there are going to be points where their muscles are so tight that that is indicated. So use your clinical judgment. We're not trying to increase range of motion with these people. We're trying to stabilize and re-educate a normal functional range of motion. So we're not really working at their end ranges either. We're going to really try and re-educate for them to identify when they're hyperextending and how to avoid that safely. So use these interventions. Keep in mind some of the positional limitations. For example, core stability is huge in this population. It's going to be so functional for them so they're not wobbling around in the car, and other things, of course, that core stabilization can help with. So as you are doing these things, you may want to have a patient plank. Well, what if their shoulders are in really bad shape and you can't have them plank just yet? Turn them around, you can have them do a V-sit instead. And so there's all different accommodations you can make like this, but always tying back to that functional core. So another one would be you can give perturbations to the head, and the goal is that they have to hold their head still when they don't know where the perturbation is going to come from next, and things along that nature. And again, I've said this before, but truly anything can subluxate. Keep that in mind. Believe your patients and trust them. I have a picture here of a subluxated rib, and I am going to actually share some videos on the channel that will show you how to identify and correct for subluxated ribs. That is something that can happen in this population, and that's one that the medical community really invalidates. They say there's no such thing, your ribs can't subluxate. They absolutely can. They do, and it's worth correcting. It gives the patients a lot of relief. And it's something that you should add to your clinical toolbox, so I'll be sure to add those videos on here soon. But the reason why I have a picture here is it's one you usually can't see on x-rays, so I thought it was exciting. You can actually see it on this one, but keeping in mind that really how crazy or wild or unique it may sound, it can happen. Just use your clinical judgment. If the connective tissue is loose and porous and stretchy, what may happen? And yes, absolutely, no matter how wild it is, it can happen. So anything can subluxate. Another consideration to have with these patients is that you want to be careful with your operations and your surgeries. A lot of times people who don't know they have a connective tissue disorder will undergo a stabilization surgery, or even if you have a joint that is failing conservative care and they wind up having to go for a stabilization surgery of sorts, usually what they would do is application surgery. And that's when you kind of fold the tissue up so it's not quite as long and you anchor it down. And so then it's a lot more tight, and that would inherently make it more stable. In the hypermobile population, where they have a connective tissue disorder, their tissue will likely stretch back out. So this is one place where you can help guide some of these decisions and maybe go to a surgeon that would be willing to do a cadaver tissue operation instead of working with their own tissue. So ultimately, I'm telling you, believe your patients and validate your patients. When they tell you something feels out of place, take the time to evaluate it, palpate it, and really get a sense, does this feel symmetric to the other side? Is this what normal anatomy feels like? If you know your normal anatomy, if you know your kinesiology and your physics, you should really be able to correct these subluxations. You just have to have an open line of communication with your patients so that they know they can tell you when things are painful and not working correctly for them. So ultimately, what I'm telling you is when you have someone with hypermobility, these concepts we've talked about for this whole time all apply. There's 14 different types of Ehlers-Danlos syndrome, and they're not the only connective tissue disorders. So you can really apply these concepts across a lot of patients. But what I do want you to be mindful with is what I spoke about in the very beginning is you can have that vascular type of Ehlers-Danlos syndrome. And that one's going to predispose you to things like dissections and aneurysms and things like that that can cause a lot more serious effects and be a bit more life-threatening. So with someone with the vascular type, you want to monitor their vitals very, very regularly. They can still exercise. You might not want to go to quite as high as an intensity unless it's something you've seen them succeed with or you've gradually worked up to. And also you want to be a little careful with your isometrics with this population. Now, that applies for everybody in this population. Of course, we never want to do something that's going to cause a Valsalva. So make sure your patients are breathing. And we've talked about some of the trouble these patients have, whether it's neurodivergence or proprioception or poor mechanics. It's overwhelming, some of the new things that we introduce. So sometimes they will forget to breathe as they're exercising, as does the typical population, but even exaggerated in this population. So make sure everybody's breathing well while they're exercising, but especially during isometrics, that tends to increase a lot of pressure within the body, have a Valsalva maneuver and things like that. So I don't often do as much isometrics with my patients with vascular Ehlers-Danlos syndrome because I'm being mindful of the pressure that puts on their vasculature, and I check their vitals several times throughout the session. Like I've said, believe your patients, trust your clinical judgment, and think of what can go wrong with a connective tissue disorder. Connective tissue is everywhere. If it's stretchy, loose, and porous, what can happen? And then you're really equipped with the knowledge to know how to treat these patients. So hopefully you found this helpful. If you enjoy treating these patients, this is another QR code. This will take you to the directory of providers that are interested in treating Ehlers-Danlos syndrome. You can list yourself if it's something that you want to do so you can be there for more of these patients. If you're looking for where to refer these patients for any of the issues that we did talk about, you can also look on here, see if that would be helpful for your patients. And I do have my references listed here. So I do want to thank you guys, and if anything else comes up, please do feel free to contact me. My Mount Sinai email is right here. That's the one I check most frequently, and I would be more than happy to connect with you, or if you're in the area, even to come meet with you. We can go over some of these hands-on testing, hands-on techniques, hands-on interventions, and some of the subluxation corrections. So really don't be afraid to reach out. I'd love to talk patient cases and have your eye on the channel for some more uploads. We're going to get more specific into how to titrate upright tolerance with POTS and dysautonomia, which is inevitably going to be key when you treat this population as well. You can't treat one without the other. And it's also going to be important for you to keep an eye out for some of the other subluxation correction videos that'll be coming your way. So we will be in touch, and hopefully we continue to work together to give these patients more of somewhere to go. So thanks. Have a good day.